So if we look at visual representations of the case illustrations, this would not be a very good one here, right? So if you, for example, if you were promoting a weight loss treatment, right? What we have here is a week 0, so you're starting the weight loss treatment, and then we see an almost immediate surge or trend downwards, right, with a progressively higher decrease, or it's more substantial decrease. The problem with this one is we don't really have any pre-treatment weight trends here. So you might have in fact already been losing weight prior to the start of this treatment. And then also you might actually gain weight after the end of it. So this doesn't give us a good timeline of the trends with regard to the case. In this case, this is a bit better because we actually have some baseline data, but it doesn't actually show us as much as we would like to see, right? So if we notice the baseline data too, it's all over the place. If this is, for example, suicidal ideation or ideas of self-harm, look at the thoughts per day. It is all over the shop. We've got a lot of baseline data, which is good, but very inconsistent. Likewise, we have good follow-up data, but it's also inconsistent. If we notice the trend during the treatment, it is decreasing, but day to day, it varies a great deal. So this is better because we do have baseline and we do have follow-up, but it's not very linear data. Finally, if we look at this one, what we see is excellent baseline data that is extremely consistent, actually shows 0. Good intervention data that shows a trend upwards. The 2-month follow-up is a little bit all over the place, but was still trending in the direction that we would like to see. So what we're seeing is established trends depending on the phase, the baseline, intervention, follow-up, and then 18-month follow-up phase as well. We see much more consistency in those trends, and this is better data with regard to an individual's treatment and post-treatment status, as well as their baseline. This is best. Okay, what we see here in the pre-training phase or the pre-treatment phase, this is children who are being receiving treatment to stop bedwetting, right? So if we look at the pre-treatment or pre-training phase, we see almost well over 90% of the nights they are having bedwetting, right? And then 1 week after the treatment, we see a 70% drop, over 70% drop in the nights of bedwetting, right? And we see a consistent trend downwards. And then when we get down to several months post-treatment, it is a consistent trend, kind of a flat, very flat trend towards both a flat trend rather, and also a consistent trend. They're both taking place in this. So this is the best illustration of data that we will see in that respect. So when we analyze the work in clinical or the success in clinical work, right? We want to consider these 5 things. We want to consider first that we want to specify the treatment goals, right? And how feasible they are. And this is something to be done with both the therapist and the client. You have to agree on these. Specifying how you'll go about them, the procedures, the processes, and the duration. It's not on there. Selecting measures. So how will you actually assess these things? How will they be measured as you move towards your goals? And then how often will they be assessed? Is it every week, every time you receive treatment, every month, quarterly? What's a realistic assessment schedule? And then how we actually design the data evaluation and how we decide whether or not progress has been made, whether or not the treatment's been successful. Are we meeting the goals established in the therapeutic alliance? The big question is if we take a step back, excuse me, that way, if we take a step back and say, well, what is the ultimate goal in this case, right? So if you're doing, for example, couples therapy, right? Are you trying to make the relationship healthier so that the relationship can endure? Or are you trying to make the separation and potential divorce healthier and more enduring, more amicable, right? So what are you trying to achieve? If a couple is attending this, I think many therapists might assume that they're trying to make the relationship better. They might actually be trying to dissolve the relationship in a healthy, amicable way, right? So how are we examining what the couples are doing, or the couple is doing right now? How are we going to decide whether or not they're experiencing improvement over the course of the treatment? So when it comes to something like, for example, an amicable divorce, are you trying to make sure that they are healing through the divorce process, that they're growing, that they're learning to become more individual, right? What thoughts, behaviors, and even symptoms, right? Perhaps maybe there's depression or anxiety in one of the 2 people in the couple. Are you addressing that? And also too, what you want to do is even, you realize just because you established a goal, so let's say the goal in this case is an amicable divorce, that does not limit what the treatment will focus on, all right? So in the amicable divorce, is going to look beyond just the divorce. It's going to look at how these two people live separately, heal from this divorce process, and move on with their lives, right? Likewise, it might also happen that as you're trying to prepare them for an amicable divorce, there's repairing that's going on in the relationship, so that they might continue to have a non-marital relationship afterwards that is healthy and potentially supportive should they have any children between them, so that everyone can receive kind of more benefits of an amicable divorce afterwards. So some things to think about too is when we're specifying the assessment procedures. What are the techniques that are going to be applied? I think participants in therapy need to know exactly what's going to be happening with them before it starts to happen, right? So do they want these treatments? Do they want to undergo these processes to meet their goals? How effective do you think the administration is going to be for this, right? The example I use in this case, and it's probably because I'm hungry right now, is this beef Wellington, right? Are you using the appropriate ingredients? And if so, are you cooking them properly? If you've ever done any cooking, you'll understand that even the best ingredients can be kind of invalidated and nullified by bad cooking techniques, and vice versa. Some people can take very meager ingredients and make a delicious dish. The example of this could be puttanesca, which is a delicious pasta dish that was made by people with very little money. What is the treatment? And the question is the treatment making the difference, or is it the administration that's making the difference? What is it? Is it the ingredients, or is it the cooking, or both? Ideally, both. When we think of assessment occasions, how often, right? At what stages? So arguably, there needs to be a lot of pre-treatment assessment, right? There needs to be during treatment. There needs to be post-treatment, right? How frequently and why that frequency? What are the intervals? Can we realistically expect someone to feel better from something the next day, right? Or the next week, or the next month? What sort of improvement trajectory can we expect realistically? And then very importantly, especially when it comes to ethics, is the client being over-tested? Are we putting the testing above the improvement? Which of course we don't want to do ever. We don't want to inhibit the improvement for the sake of very, very frequent testing. So got to be cautious there. Got to walk a very fine line with regard to that. When we evaluate it, so how are we going to evaluate this, particularly in a way that the client might see? Me being a stats person, I love statistics. Statistics speak to me very clearly, but for most people they don't. Right? So if your therapist was to say, oh, I think you've made a statistically significant improvement since the beginning of this treatment, most people aren't going to know what that means, nor will they care. But if you can see it, like if you can visualize, use a graphical representation of how people have improved, or point out the ways in which they've improved, that's going to make a big difference. When I was in college, I experienced a pretty severe depression after the loss of a good friend of mine. And it wasn't about knowing that I had scored lower on a depression inventory after the therapy. It was more about how I felt day to day. And my therapist did an excellent job to point out, look, you're feeling these things, which are good, and you're not feeling these other things, which is a good thing you're not feeling them anymore. So it's very important that the client realize what changes are being made in a way that will speak to their experience and help them grow. So I'm a big fan of graphs. Make graphs, not war. So some clinical issues that we need to address, and I'm using this picture in the bottom right. I imagine many of you are familiar with the case of Jeannie. She's referred to sometimes as a wild child. She was an unfortunate case of a young woman who was essentially kept in a cage for most of her young life, and thankfully was discovered and freed, and then rehabilitation was attempted. But in her case, what they did is they prioritized their research over her treatment. I'd invite you to read, there's an excellent book called Jeannie, A Scientific Tragedy, by an author named Russ Reimer. Excellent book. Sad, but very, very good. And it talks about how the therapist actually prioritized their research, their own research and their own grants over her treatment, right? And this is simply not appropriate. In any case, the client should always come first. Their needs should always come first. And you never want to oversimplify the problem. Jeannie had issues with cognition, behavior, phobias, social interaction, basic tasks. All of these need to be addressed, right? And in her case, they did focus on her uniqueness, but didn't focus on how she was constantly changing. She essentially was growing by leaps and bounds before their very eyes, and they did not adapt. Their treatment stayed static and was not dynamic. And all of these were reasons why it is considered a scientific tragedy. I'd invite you to read up on it. Trigger warning, it is sad and does detail quite severe psychological and physical abuse, but it does get at the heart of the importance of examining the treatment with a higher regard than the research. So things to consider as we conclude this. I'm going to throw this on here. Always with my transitions. I don't know why I do this. I think it makes the slides look cooler, but it doesn't actually. It just, anyway, whatever. The client comes first. I put that as the very first priority. Make sure you underline that, highlight it, bold it, whatever. That is the most important thing. The people come first. But you also want to take a moment to identify what you're dealing with, right? Identify the issues, identify the problems, identify the goals. That's the next bullet point on there. What are the goals? What are they trying to achieve, right? If you look at someone who's got a severe phobia, obviously you want to help them overcome the phobia, but you might ask them, start out by asking them, okay, what is your goal in all this? And they might say something simple like, I want to be able to go to the grocery store again, right? That's their goal, being able to go to the grocery store, not overcome this phobia and never have to worry about, being in social situations again. No, just be able to go to the grocery store, right? What we want to do is we want to make sure that as a therapist or a researcher, we want to design and tailor the measures to suit them. That's where the picture of the tailor comes in, right? It's not a one size fits all, whether it be treatment or research. It is not a one size fits all. We need to assess as often as is feasible. Make sure you add that there. Assess often, but as often as is feasible. And we need to be prepared to adapt. Just because we have established a treatment or a research technique that we want to utilize doesn't mean it doesn't need to change. Through constant evaluation, and it should say evaluate and reevaluate often, we might find, wow, this was working at first, but it's not working anymore. Let's change. Or this symptomology seems to have gone away, but this other symptomology seems to have popped up. Let's find a different way to assess, right? And we want to make sure that we assess against preset goals, right? If this person has a debilitating fear of even considering social interactions, having them engage in a social context even for a brief moment is going to be a goal, and it's going to be success, right? And then, as I said at the beginning of this PowerPoint, and then as I said at the beginning of this slide too, do not sacrifice the client to science or statistics or research. Just because someone could provide good research data or a good new therapeutic technique, or could be the way for you to get a grant, that's not the purpose. As we talked about in the ethics chapter, you are not doing research and you're not doing therapy for your own benefit, you're doing it for the benefit of other people. So we want to make sure we keep this priority in mind, particularly when there's a severe case or a unique case. Do not let the uniqueness or the severity of their case kind of override your concerns about them. Make sure that they are always put first, so that their treatment and the successful treatment is always your ultimate goal.